Good evening and hello everyone. Today the topic of discussion will be on infectious mononucleosis. It is a spectrum of clinical manifestation which is caused by Epstein-Barr virus, which belongs to human herpes virus 4. This disease is also named as glandular fever as it is presenting with a generalized lymphadenopathy or also kissing disease. Kissing disease because the transmission is through saliva. There are various other conditions which mimic the disease, giving infectious mononucleosis like symptoms. So these are viral pharyngitis caused by influenza or adenovirus, streptococcal pharyngitis, cytomegalovirus infection, toxoplasmosis, human herpes virus infection, and other viruses like hepatitis virus, rubella, herpes simplex virus 1 and 2, and human herpes virus 6. Now come to epidemiology. The factors influencing our level of hygiene and cultural practices. In many cultures, they have a practice of giving pre-chewed food to the infants. So this is one of the source of infection. And coming to the spread of the manifestation of the disease, in the developing countries, it is noticed that 80 to 100% cases are infected at age less than 5 years, at a younger age. But at this age, the disease is clinically silent and so it is mild. Whereas in the developed countries, the peak age is 10 to 30 years of age, the disease is manifested, and then at this age, the disease is clinically manifesting like mononucleosis syndrome. The incidence is 50 to 100 per 1 lakh population, the highest incidence being noticed at 15 to 19 years of age. There is no seasonal predilection. It is higher in the white race than in the other ethnic groups, and the reservoir of Epstein-Barr virus is only humans. Now come to transmission of disease. Incubation period of this disease is 30 to 50 days, but in children, younger children, it is shorter than this, maybe 6 to 8 weeks. And it is transmitted through the oral secretion, maybe by giving pre-chewing food for the infants or via oral kissing. Parenteral blood products, bone marrow transplantation, transplanted organs are also responsible, but this mode of transmission is less common. And intrauterine transmission is not common. Very rarely, if it occurs also, there is no viral transmission to the fetus, so there is no adverse outcome to the fetus. Come to pathogenesis. First, there is entry of virus into the oral cavity by salivary fluid transfer. And then it infects the oral epithelial cells, giving rise to exudative pharyngotonsillitis. Then there is viral replication in local lymphatics. Then there is cell lysis, which releases new virions in the bloodstream, and then here it infects the B cells. Then it spreads to contagious structures of the reticuloendothelial system, that is liver, spleen, lymph nodes, causing viremia. And at this time, this is a secondary viremia, so at this time, it gives rise to clinical symptoms. Epstein-Barr virus is found in saliva for first 12 to 18 months after the acquisition, after acquiring the infection. The viral replication is occurring in the reticuloendothelial system, which are lymphoreticular system, liver, spleen, B lymphocytes in the peripheral blood. And the disease is manifested with a triad clinically, that is any child who is having prolonged fever, if has pharyngitis, lymphadenopathy or fatigue, then you should highly suspect infectious mononucleosis. The clinical feature or different phases of the disease are prodromal phase. It is lasting for 1 to 2 weeks. At this stage, patient is fatigue and malaise. Then comes the acute phase or acute period. During this, there is a prolonged fever which may last for 1 month. And then sore throat, pharyngitis, generalized lymphadenopathy, retroorbital headache, nausea, abdominal pain, hepatosplenomegaly. Then comes the resolution phase, which is lasting for 1 to 3 months. At this phase, the organomegaly is persisting. So now come to the description of the different clinical manifestations. Fever. Starting with fever, 93% cases they have fever which is prolonged. So it may be 2 weeks to 1 month. And fever may be associated with chills and rigor. So sometimes you get confused with malaria. 82% cases has pharyngitis, and this is the most consistent finding. 1/3 have exudative pharyngitis in first 1 to 2 weeks of the illness. 25 to 60% cases has petechia at the junction of the hard and soft palates. And there might be tonsillar enlargement which can be quite massive and then cause airway obstruction. That is one of the emergency. So a child having a respiratory distress, and then maybe the child is brought to emergency room. So this is a exudative pharyngotonsillitis of infectious mononucleosis. You can see discharges or exudative discharge in the crypts of the tonsils. Lymphadenopathy is seen in 95% of the children. So lymphadenopathy is symmetrical, mildly tender on palpation. The involved lymph nodes are posterior cervical is the most common, but anterior cervical, axillary, submandibular and inguinal nodes can also be enlarged. Enlarged epitrochlear nodes are very suggestive of infectious mononucleosis, so you should always look for palpate the epitrochlear lymph nodes if you are suspecting infectious mononucleosis. 11% has hepatomegaly. Jaundice is rare, but they have a deranged liver function. The liver can be tender on percussion. 50% cases has splenomegaly at 2nd to 3rd week of the illness, and it is palpable 2 to 3 centimeter and also may be tender. And spleen can rupture with a minor trauma, and even spontaneously spleen can rupture. So when you palpate spleen in this, if you suspect infectious mononucleosis, you should be very gentle. Don't palpate the spleen with a very hard hand. So your hand should be very soft. And the spleen starts decreasing in size in next 7 to 10 days. So this is a picture showing cervical lymphadenopathy, hepatosplenomegaly. Another manifestation is rash. So that is 3 to 5% cases has a maculopapular rash. Usually it is faint, widely scattered and morbidly formed, or papular erythematous rash is seen in the upper extremities or trunk. 80% of the patients develop rash if they are treated with ampicillin or amoxicillin. So rash is associated with the ampicillin amoxicillin. 15% cases have eyelid edema, which may be present especially in the first week. So this is a rash which appeared after giving amoxicillin or ampicillin in a case of infectious mononucleosis. Thank you. I'll come up again with the investigation and treatment part in the next class.